please.
Thank you very much, Jürgen. Thank you very much, Peter, for inviting me to talk to this important topic. After this presentation on the complications is the question, how could you prevent all this? And he gave me a talk with the title boring, but important. So I hope that the next 10-15 minutes won't be too boring for you. So the basis for all these preventive mechanisms is that you have to think what you want to do and that you have to standardize your endoscopic procedures. That sounds simple, but everybody who has tried this realizes that it's really very difficult to give you a very standardized approach to what you're doing all day. So what you have to define is so-called SOPs. We all know this, standardized operating procedures. And what are these? These are clear definitions, not only for the medical part, but also for the co-workers you have on detailed tasks and commitments of everybody who is involved in the process. And this is irrespective of what occupational group they belong to, so whether they're the doctors, whether they are the assistant personnel, or whether they are some supply staff. There must be a clear definition and a clear wording of the responsibilities. So who is responsible for what? And then it is important to define SOPs for the typical processes in endoscopy, like upper GI or lower GI endoscopy, but also for the more specific procedures. This is extremely important for the all-day work, but it's also very important if you train new co-workers and if you introduce new techniques. Then you should collect all these SOPs so you can find them, that you don't have them on only in a folder somewhere in your office, but everybody can access it. And so it's, in the meantime, usually that you post it in your intranet or in your guideline book, that you print some check cards, as I will show later on. So what endoscopic standards should we define? We should define the equipment, the hygiene process, the patient safety, so all the procedures associated with the patient safety. And we also should define the knowledge and the training and the skills of the endoscopists. This sounds easy, but it is very difficult. If I hear from you that there is somebody on call who can't do ERCP, then he shouldn't be on call. That's very simple, because you have to define who can be on call. If you have the risk of somebody bleeding from the biliary system, there has to be somebody on call who knows how to do ERCP. So the next step is, so you go through the endoscopic process. So you look first for standard for the preparation of for the endoscopy. So there are some basic principles. You have to check the identity of the patients. You have to check for infectious diseases. They're usually house-wide standards. That's something not you have to invent for endoscopy, but you should have for all the other invasive procedures. Then there are standards for informed consent. These are given by usually your insurance companies. And then there are standards for coagulation, contraindication, and risks of patients, as you have heard before in the last talk. Then there are simple standards like IV cannulas. We, for example, had a big problem with paravenous injection of IV cannulas. And we tried to find out how can we solve this. And there is a very easy solution to this, which we now do, is we just put on an IV solution in the daycare clinic, and if the IV solution is running, then you don't have a paravenous infection. Since we do this, our paravenous injection rate dropped from 30% to 0.5%, which is important because if you have a paravenous propofol injection with an abscess, it's a major complication for this patient if he just has a routine colonoscopy, for example. And so the next step is, if you have these SOPs, you have to promote them. You have to distribute them in the various ways. So you should either have an intranet with the guidelines, or you have what we call quality measure book, or you should have definitions for the daily work, and you should also distribute them in your multi-professional team. One way to do this, except the computerized way, is to make these check cards, which is one of my topics. So you should have these checklists for both the nurses on the board, for the nurses in the endoscopy, but also for the young doctors, where everything which is needed before a procedure, on the procedure day, or after the procedure is actually documented, and where you can actually go down. And so before the procedure, there are some things like you should check the identity, you should check the informed consent, the risk factors, and the lab values, because that's important. If this is not present, the procedure shouldn't actually start, so the patient shouldn't go to the procedure room. Then there should be a check of the room, the material, and the endoscope, and the techniques you want to apply. You should check again the IV cannula. You see, this is a very big issue, because if you have a problem there, this is something, it is really difficult to justify if you have such a complication. Then you should start the monitoring. It should be clear who puts on the monitoring, who checks the monitoring. As you know, in Germany we have the NAPS sedation, so the nursing staff is doing the sedation during the procedure, but you have to make clear how the sedation process is started, because the start of the sedation is usually something which has to be done by the doctor, so it has to be defined when is the monitoring start, who does it, and how is it documented. Then there should be a routine check of all allergies and, for example, of increased blood eye pressure if you have a glaucoma or metal implants. We have several step routines, so usually the patient is asked at least 3 times until the procedure starts. First, during the informed consent, second, before he actually enters the room, and then immediately before the procedure. So he will be rechecked for these questions, and there will be a check of all the medications like antithrombotic medication or oral anticoagulation. Then you should have a correct positioning of the patient. That's normal. Then during the procedure, you should check if there is a correct image storing, and you should for sure check all the vital signs and document them during the procedure. After the procedure, there also should be definitions how you should remove all the, for example, the dental ring, or we have a very clear procedure how to put up the safety bars on the stretcher to really rule out that the patient can fall off the stretcher. And you have to have clear monitoring instruction while the patient is in the room or he's transported to the daycare unit. This has to be clearly defined. And you have to have a clear documentation how your specimens are labeled and are also given to the pathology unit, because if you mix them up, that's a major complication. There could be a major complication if there is some handling errors. And then you have a clear documentation of your reporting of the endoscopic procedure, and you also should have a reporting of the pre-processing of the scope while it's in the room or it's transported out of the room. So usually you have this in an intranet, in a quality measure book, or in any other technical solution you have in your hospital, where all the information to the procedure is again given, like on these report cards. It's also advisable to have a standard operating procedure for the endoscopic staff. So how should the endoscopic table be organized for a given procedure? Like this is a standardized table we have defined for an ERCP with a planned endoscopic papillotomy. And you should define this once. You should define the general workflow, the hygiene rules, and you should also define the material and the equipment. And if you standardize this, if you know how an EPD is done, that can be relatively good standardized down to the question what papillotome with which guide wire is prepared before you start the procedure. It is very important to define who does what what is needed, and to also give an explanation why this is done, and that everybody who is new to your department will understand this. And there's another example for placement of a gastric balloon, for example, just to give you how the individual equipment and materials are organized on the table. Checking identity nowadays is easy. Most of the hospitals now have this hand bars where you can check the name and the birthday, but still you should at least 2 times let's say in a 4-hour principle, ask for the identity of the patient. We have this 4-eye principle in every patient, and as in Germany, we have many Schmidts and many Wolfgangs. So if you have a Schmidt-Wolfgang, you are very likely that you have 2 or 3 patients in the hospital at the same time. Then there should be a standard for the endoscopy itself. So for the preparations, what does fasted mean? Fasted means no food, but drinking should be allowed, even up to 2 hours to the procedure. And there should be some exceptions which should be defined, such as gastroparesis or achalasia, where you should have a defined preparation process. And then you also should have a standard for the anticoagulation. We will have a talk later on, and this will be a topic in a subsequent talk, but you should define this beforehand. When should the anticoagulation be stopped for a given procedure, and what borders are defined for a normal intervention. So you should discuss this in your group, and we have such suggestions in our guidelines in Germany, but we also have it in the ESG guidelines, and that's some suggestions we use there. Then you should have procedure standards. You should have a pre-oxygenation with O2, which is recommended. You should have a standardized surveillance of the patients, and then a standardized sedation procedure. We usually use a NAPS, administered propofol sedation, as a standard in our unit, and only if the patient is at risk or in a risk procedure, we do it with a second doctor or even with an anesthetist if needed. There are some general definitions of what is a risk patient, and this is defined in various guidelines, and I don't really have to go on to this. And then there is a clear recommendation how the informed consent of the patient has to be done. The most frequent problems, if you work as a Gutachter, as somebody who has to judge for legal processes, is that the signature on the informed consent is not done in the beforehand, but it's done in the procedure room or on the stretcher, which is not legally acceptable. If you look for the second topic I got, the team timeout, it's relatively difficult. If you look into the Medline and look for team timeout and endoscopy, there are only 3 hits actually, and one is just a review, and there's only 2 studies which look at team timeout and the effect on the quality in the procedure. One is from Great Britain, and they really studied in a very interesting approach. It is clear that team timeout is an established standard for surgical interventions, and there's a very interesting task force. I never heard of it. It's the Surgical Never Event Task Force. I never had knowledge of this, but I thought it's a good name for such a group. And they defined a national safety standard for invasive procedure in Great Britain, which is a very interesting paper to read. And from this, they defined local safety standards for the individual hospitals. So how should be the local safety standards? And they could show that this reduces the complication rate in the general all-day procedures, and especially if you induce new techniques and new staff. And these 2 papers looked how these standards, these local safety standards, can be introduced in endoscopy units, and they found that yes, it is not a self-running process. So if you do it, and even under study conditions, in the first year they only reached about 75% where they had this standard completed with these standard safety cards. And after 1 year, they reached almost 90%. And you can see that the differences in the documentation were quite substantial. But specimen labeling was good, but reached only 90%. Anticoagulation plan was about 75%. So there were problems even if you have this under study conditions. And there is a learning process, so it needs some time to incorporate such standard operating procedures, even with safety cards, into a relatively big and good organized endoscopy unit. So yes, we do have some room to the top, and we should incorporate this in our daily work. So the team timeout in endoscopy is a structured stepwise analysis of a planned procedure. It should be multi-professional, so it should involve the endoscopist, the assistant personnel, the aftercare unit, such as the ICU or the anesthetist if present, and it should include as the factors I already mentioned, the identity, indications, risk factors, and so on. But it should mainly include the planned procedure, so is everything prepared, all the materials prepared, are all the alternatives present, like guide wires or the stents? What are the anticipated complications, and are these equipments which can handle them prepared? And then there should be the adequate positioning and sedation for the patient for this procedure, and there should be also function testing of the whole equipment. And this should be done immediately before the procedure, and all the studies, at least from our surgical colleagues, show that these team timeout will actually reduce the stress during the procedure and will also reduce the complication rate. Thank you very much.
Not boring at all. Thank you very much, Hans. But it's different compared to reality in most of the units. And may we ask, like, how many here in this room do have patient safety cards implemented in their endoscopy units? Hands up. Okay, I think your talks from the past, they show effective now.
Yes.
Questions and comments?
Can I ask a question, Jürgen?
Yes, sure.
Who here does a formal timeout before every endoscopy in their department? And it's with documentation where it's written? Okay. Yeah, we have, it's mandated in Israel because we're actually JCI approved hospital. JCI is the Joint Commission from the United States. And so there's actually 3 steps. At the initial intake of the patient, the nurses then go back over, and then immediately before we drop the scope, the physician, in fact, I've empowered our nurses in our department where it's the nurse that calls the physician who's doing the endoscopy. Professor Groundlich, you need to come here. We're doing timeout right now. And we go through the checklist together, and then the scope is dropped at that point. It was very interesting because to get this all processed, it's a little bit different at the management level of the hospital because they think it's like the surgical timeout. We said it's not the exact same as surgical timeout, but it can be adapted to it for endoscopy, and that's what we've done. But I think it's exceedingly important, and you gave a great talk about this.
Yeah, but the problem is that's the theory. And I agree completely with you that this is when you have a relatively complicated procedure, you will do a team timeout because you plan all things together. You see this if you go to live transmissions. That should be our standard. Because in live transmissions, you plan every, more or less every step, small step. You say, well, I will do this, I will put in this, I will do this, and then I will show this, and I will turn the knob, and then you will switch to there. So that's the extreme form of a team timeout. But if you go back to your daily routine and you think there are 2 more ERCPs to be done, there's a stone in the distal bile duct, and you go in, just check yourself tomorrow or next week, how often is it really done? So how often do you really do this team timeout during a routine, like a really routine procedure?
So in our department, for every endoscopy, the team timeout is the nurse who's doing the endoscopy with the doctor and the doctor themselves, okay? So it is required at every endoscopy, and I've empowered the nurse to say, I've told them, you do not start the procedure until the formal timeout has been done with the physician there. And if you get any problems, you talk to me as the chief of the department.
Okay.
And I'll take care of it. So us, we really push to do that.
I just want to say this study, and I find it very interesting and very honest, was done in a prospective manner in an excellent hospital in Britain, and they reached under study conditions, so they know that they are observed, 75%. That's the reality. I mean, and I don't think we live up to that under normal conditions. Okay.
Please take a microphone.
Which points are mandatory for a normal colonoscopy for you at a team timeout? What to discuss? Exactly.
I'm going to let Shuan, because she's going to also talk about this.
So very briefly, that was our study from St Mark's, the
Yes.
implementation of the checklist, and I'd echo what you say. So we do it, as you say, in every single endoscopy. I would love to say that it's done perfectly every time, but we know that it's not, even under study conditions.
It's an excellent study. May I congratulate you?
Thank you, but it needs to be reiterated. So in the UK now, we have to audit the checklist, and there are actually 3 ways of auditing that it's done. 1, was it done? Yes, no. 2, an audit of how many of the boxes were ticked.
Yes, so
and
that-
3, an in-room audit, which is done infrequently to actually watch it being done. And of course, that's A, the most difficult to do, and B, the most rewarding in terms of what happens, because not everybody is engaged. I'd also echo what Ian says about empowering the nurses, and I'll perhaps touch on that in my talk. But in answer to your question, I think the factors that you've listed there in terms of reiterating patient identification, it isn't just patients with the same name. I won't go through all of the factors, but it's patients with similar name.
Yes.
And you only have to do a procedure on the wrong patient, well, I would like to say once. It's happened more than once in our department, to know that that's important. Patients, we have patients with the same name and same date of birth, so you have to
Yes.
check a 3rd or 4th ID point as well, hospital number and address, because patients will agree to almost anything. So we've had the wrong patient turn up for a procedure. They didn't even need the procedure, and they've got the same name and date of birth as the actual patient. So people, if you call them to hospital and say you need a test, they'll come. So you have to be really, really careful.
And if you just ask them, are you Mr. Schmidt receiving a colonoscopy, he will say yes, even though he's come for a bronchoscopy.
You can look online, actually, and there's listed checklists of what you go through immediately prior to dropping the scope.
I've got that checklist, but it is done only by the nurse before the procedure. Is that enough?
No.
Why not? The nurse asks the patient about the birth date. And
Yeah.
so
Well, in our unit, it's done while the doctor is in the room. So I check it while I'm. So
all the points indicating platelets,
usually it's
coagulation.
done. I go to. Usually the work process is that the doctor goes through the records again of the patient, where the nurse is doing this checklist questions, and so you hear actually what the patient is being asked, and so you have a backup, and then there is the team timeout for the procedure. That's 2 different things. You first have an informed consent interview with the patient the day before, where you already ask all these questions. Then these questions are asked again before the procedure by the nursing staff in your presence. And then you usually, before you start with the sedative process, you do the team timeout. That's our approach.
I'll just add one more point. I think that if there's an adverse event or there's a problem that becomes medical legally, you're ultimately responsible in that room. So the judge will ask me, so Professor Graulich, where were you during that timeout?
Yeah.
All right, so it's going to be hard to answer that question if I wasn't there and wasn't part of the process.
In Germany, it's in the moment not mandatory to do a team timeout, but I think it will be a recommendation from the insurance companies.
Well, once it's there, it becomes legal, right? So, last question, how many minutes are added, by the way?
Sorry?
How many minutes are added by this whole thing? 1 minute. That seems reassuring. Okay.
I don't know if 1 minute is enough, but let's say this way: it's a process which is included in the general preparation process of the patient. But the team timeout usually requires at least 1 minute.
Okay. So thank you very much.